Hi, my name is Stephanie Genicus and pronounced she, her. I'm a nurse practitioner at Student Health, and today I want to talk to you about PCOS. PCOS affects about 6 to 10% of the population with ovaries. And today I want to take a look at what the differences are in a person with PCOS and how that can affect the body. Sometimes when there's a better understanding of what is happening physically and mentally, it can help one accept those differences and work with the body to be as healthy as possible. PCOS is a bit tricky because it can act differently in different people. To diagnose it, we look at 3 categories, and for a positive diagnosis, a person needs 2 of the 3 findings. The first one is menstrual irregularities, so cycles greater than 35 days apart or fewer than 8 menses or periods per year. The second one would be increased androgens, either in the lab, like if we draw your blood and you have an increased testosterone or DHEA, or as a measure of hirsutism. So that's going to be cis male pattern hair growth. So like on the face, chest, upper legs. These androgens can also cause acne and hair loss on the scalp. The third one is the appearance of the ovaries on ultrasound. So the ovaries on ultrasound are going to have a bigger volume, and they're going to be having 20 follicles or more per ovary on either ovary. So you can see here a picture of this PCOS ovary, then that's the A, or the standard ovary, B. And I think a lot of people think about polycystic ovary and think, oh, my ovary has all these cysts in it. But actually, it's not true. It's just the ovary is a little bit bigger, and it has a lot of these antral follicles, these small little follicles. So you see that in that slide under the polycystic ovary. And then the standard ovary has fewer follicles, and then it has one that's starting to get bigger because that's what happens as the egg starts maturing. So that's an ovary that's like probably mid-follicular range, and so that's what it's looking like as the egg is starting to mature. So not a huge difference, in size, and definitely not a bunch of cysts. It's just a lot of antral follicles. And you might wonder, why me? Why do I have PCOS? We're not totally sure, but likely it's a combination of genetics, environmental exposures, and transgenerational. So that would be like your birth mom having PCOS and then you having prenatal exposure to those maternal androgens, those testosterone, DHEA type hormones. Let's meet the major players of PCOS. So first, insulin. Insulin is secreted by the pancreas. It helps regulate the blood sugar or blood glucose. The insulin acts as a key to open the door so the glucose can get into the cell that needs the glucose for energy. Then we have androgens. These are the sex hormones like testosterone and DHEA. They are the dominant hormone in those assigned male at birth, but folks with ovaries also need some to help with bone density, muscle mass, and sexual function. We have LH, which is luteinizing hormone. Along with FSH, LH is secreted by the pituitary gland in the brain. LH is the one that triggers ovulation, which is the release of the mature egg. If LH is too high early in the cycle, it can block the FSH release, which blocks the egg maturation. So it's important to understand the menstrual cycle with PCOS. This is a complex feedback cycle and is thrown off in PCOS due to the excess of insulin, androgens, and LH. We're born with all our eggs, and each month a group of follicles rise to the surface of the ovary, each of those containing an egg. So think of that picture we saw with the PCOS ovary and the regular ovary. Those little dots are the follicles. One follicle is selected, and in that follicle, that egg will mature with the FSH that's released from the pituitary gland in the brain, and that growing follicle releases estrogen or estradiol, and that estradiol will increase the thickness of the lining, and eventually it gets high enough to trigger the fancy feedback stuff, and then an LH surge happens, and boom, the egg is released. So then the egg is picked up by the fallopian tube, and this follicle turns into a corpus luteum cyst, which is a functional cyst. Progesterone is released, so here we have our progesterone, and that stabilizes the lining. If there's no pregnancy, the body recognizes this, and the hormones drop, and you get your period. So the pathway from eating to energy storage and the negative feedback involved with insulin release confuses me. So I drew a picture to try to illustrate what is happening and how this changes with PCOS. Obviously, I was not an art major. So we start with our person eating their meal, and then we have the glucose from this healthy meal entering the bloodstream. So all the little red dots are our glucose molecules. So this goes through, and then it triggers the pancreas to release insulin. So those are our blue squares. The insulin, if you remember, is like a key that opens the gate so that the glucose can get into the different sites for energy and storage. So we have first, most important, we have our person who needs the glucose right away for brain and muscle function. And so this insulin opened up the gate here, and lots of glucose can get in. Then we have the area where we're going to have some storage. So we have our glucose and our insulin moving through the bloodstream. The insulin opens the gate and allows some more glucose here into the liver for storage for later use. And then we have the little bit of leftover here, some insulin and glucose moving down, and it's going to get opened up here by the insulin so it can get stored in the fat cells. As the glucose enters these sites, the level goes down in the bloodstream. So you can see here was gobs and gobs of them here. And then now we have just very few of the glucose. And then the pancreas is signaled through a negative feedback to stop producing the insulin. Now let's take a look at what happens in the system of the person with PCOS. There is insulin resistance in many of the cells where the glucose needs to go to provide energy. So you can think of it like the gate is really heavy and you need more and more insulin to push it open to let the glucose through that cell. So here we have our person eating their healthy meal and the glucose entering the bloodstream. That glucose signaling the pancreas to release the insulin. So far everything working according to plan. But you've got all this insulin and this gate to the cell is just not opening as well. So just not as many glucose are getting through for a person that needs it for brain and muscle function, and a lot is staying in the bloodstream. So then we move along. We still have a lot here, so some will go into storage for later use. Still, that gate is just really not letting it through very well due to insulin resistance, so we still have a lot of glucose in the bloodstream. We need more insulin to be made from the pancreas, and then we're going to end up having a lot stored in the fat cells, and we're going to end up with a higher glucose level, a higher insulin level, if we did a blood draw and checked that. Insulin resistance. How does it affect the body in PCOS? Let's look at a few of the ways. So, insulin triggers the release of LH from the pituitary. When we think back to the menstrual cycle, we know that both FSH and LH are released from the pituitary. Both are important in the menstrual cycle. The FSH needs to be the dominant hormone early in the cycle because it's helping to mature the egg. As it matures the egg, estrogen levels go up, and once the estrogen gets to a certain level, it can trigger an LH surge, and that's what will make ovulation happen. So if you have excess insulin triggering the release of LH too early, that will interfere and suppress the FSH. then you don't get the maturing egg, you don't get ovulation. This will cause irregular cycles. So then you have months and months with no period, or sometimes just irregular bleeding because that progesterone is not released to help stabilize the lining in the second half of the cycle. Another way that insulin resistance affects the body is that it increases the production of the androgens in the ovary. This can lead to hirsutism, so more hair growth on the face, chest, abdomen, thighs, increased acne, and sometimes hair loss on the scalp. Excess androgens may increase the risk of sleep apnea. And excess insulin and excess androgens may cause mood changes like depression and appetite changes like food cravings. Insulin resistance can promote increased fat storage in the body. So think back to the slide with the little person eating their food, and in the PCOS system, the glucose remained in the bloodstream. Because of that insulin resistance, it couldn't get into the cells that needed it. And so then it's in the bloodstream, it's causing inflammation, the body has to get it out of there, so it puts it into the fat storage. So this can play a role in body composition changes. It's not just about food intake and exercise. There's also a need to decrease the insulin resistance. So we've talked a lot about how things work in the body when someone has PCOS. And with about 10% of those with ovaries having PCOS, you can really think of it as a variation in physiology. And learning about these differences in the physiology and the reasons for the physical changes can be empowering. It can help with acceptance and finding ways to feel healthy and good in your body. So you have a support team at Student Health Services. You can work with our registered dietitians to learn about food choices that can avoid spikes and drops in blood sugar. They have valuable perspectives and strategies for building a positive relationship with food. They take into account the reality of each individual's living situation and food access to help make a realistic and achievable goals. Our medical providers will learn about your medical history, do necessary testing, and work with you to find the best pathway towards health, depending on your needs and goals. For some, this will involve check-ins for support and monitoring with labs, and for others, medication. Our behavioral health team is here to help you manage the mental health challenges like depression and anxiety and disordered eating that can be associated with PCOS. With talk therapy and tools like cognitive behavioral therapy, those struggling with their mental health can find new ways to cope. There's a few things that we'll need to focus on clinically when we're helping you stay healthy with PCOS. If you have irregular cycles, we'll want to protect the uterus. So it's necessary to prevent the endometrial cells from becoming abnormal and causing endometrial hyperplasia. So when there are no menses for over 2 months due to PCOS, those endometrial cells can just be in there and they can become abnormal, in rare cases leading to cancer. So what we want to do is we want to prevent those endometrial cells from being in there for too long and becoming abnormal. So the way to do that is to keep the lining thin. And we can use birth control pills, and the bonus with those is it also helps lower the androgens. We can use a hormonal IUD or Nexplanon or Depo-Provera. We can induce a period with oral progesterone, and so for somebody who didn't want to take hormones all the time or have some sort of birth control method, this can be done just taking the oral progesterone for 5 to 10 days every 1 to 3 months just to shed that lining. There's also ways to just suppress the menstrual cycle altogether, which for some people is a really nice thing. Another thing we'll focus on is preventing insulin resistance or treatment for insulin resistance. So this would involve learning about food choices and best combinations of foods for a steady supply of glucose and energy, finding an activity that brings you joy to build muscle, which helps reduce insulin resistance. And some people may meet criteria for a medication called metformin, which helps reduce insulin resistance. We also have options for treating symptoms like acne and hirsutism, the extra hair growth. We can use birth control pills. We can use an additional androgen blocker called spironolactone. And for scalp hair loss, we can use topical minoxidil. And there's also a referral through SHIP insurance where you can use your insurance for electrolysis. There's partial coverage for that at locations outside of UCSD. We look forward to working with you. You can call Group 4 to set up an appointment with one of the medical providers, and that would be 858-534-2669, or you can make an appointment through your MyChart. There's also an amazing app that you can download. It's called Ask PCOS, and it has so much information, research-based, really helpful. So I would suggest that as a way to get really great information. There's so much there. Again, it's Ask PCOS. Thank you so much for listening. We hope to see you soon.